fevers in the Indian setting. So, first of all, we think of tropical infections, and like all of you know, at this time, we are seeing lots of cases of dengue. Apart from that, we have malaria, we have typhoid and paratyphoid, leptospira, rickettsia, chikungunya, even Zika. So these are Zika, not so common in India, but coming up. Then we have various viral infections. Now, when we talk about influenza, you think that this will be a patient who will have fever, cough, cold. But there are lots of cases of flu, which initially in the first 3 to 4 days can just present with fever with no localization to the respiratory tract. All of you know about infectious mononucleosis. Want to talk a little bit about adenovirus infections because we are seeing a lot of adenovirus infections this year. And this year in Mumbai and in India, which are presenting with prolonged fever with no respiratory manifestations. 2 years ago, when I did this lecture, I was talking about COVID-19 as a cause of fever, but now we are hardly seeing any COVID prodrome of acute viral hepatitis where you can just have fever. And then we also have bacterial infections such as urinary tract infections, bacteremias, pneumonias, and sinusitis. So pneumonia, you often just present with fever. You may not have cough, breathlessness, especially in the elderly people. And in children, we see often sphenoid sinusitis coming with just fever and no other respiratory manifestations. Now, this was one study which was done in India, which they looked at. Basically, they studied, this is almost about 10 years ago, where they studied 1,500 patients with short duration fevers at 7 community hospitals in 6 states of India. And they found that the most common causes of fevers were dengue, followed by malaria, then typhoid, paratyphoid, chikungunya, leptospirosis, and scrub typhus. Interestingly, what they also found that the epidemiology differed across the various states. There were patients who had overlapping case definitions, and third, that there were patients in whom there was several diagnoses were made due to cross reaction between serologic tests. That means you had malaria and yet your dengue serology was positive. So we must understand that these are some of the problems in diagnosing short duration or undifferentiated febrile illnesses. So before we go to the lab test, let's talk a little bit about what are the clinical clues which help us in diagnosing the cause of this fever. The first are the epidemiologic clues, like the geographic location. For example, there will be areas in India like, for example, the Konkan belt or Sholapur or Tamil Nadu, where there will be a lot of rickettsial infections, which are less common in Mumbai. Then it also depends on the season. So, for example, in this season in Mumbai, the top 2 causes of acute febrile illnesses are dengue and leptospirosis. And third, also on basis of contact. So, if you have one person with dengue in the family and the other person also develops fever, then you think that more likely it is to be due to dengue, because although the illness is not transmissible, but you have the same mosquito biting both the people. So those help. Then we also look at the pattern of fever as clinicians. And that is extremely important to try and take a detailed history about how has the fever progressed. So what was the onset? If the onset was low-grade fever, then over day 4 or day 5, it becomes high. Then we are thinking of typhoid, paratyphoid. On the other hand, when the onset is absolutely catastrophic, high fever on day 1, and then tends to either come down by day 3, day 4, or has a biphasic pattern, we are thinking of illnesses like dengue or influenza. If we have an intermittent fever pattern where you have fever every 48 to 72 hours, you think of malaria, but that pattern of fever in malaria usually happens after the first week, and most patients are already diagnosed by then. Also, it's important to know that the pattern of fever is confounded by the use of antipyretics, because nowadays there's so much of fever phobia that people are more worried about the fever than about the cause of fever. So they will keep taking ibuprofen, paracetamol to bring the fever down, because of which it is not possible to ascertain the pattern of fever. But sometimes you can actually ask the patient about how much was the need for antipyretics 2 days ago vis-a-vis today, and you can try and decide whether the fever is actually getting better, which means it's a viral, or it is getting worse. Now, chills and rigors are not useful. because you can have chills even in influenza, you can have it in pyelonephritis, you can have it in abscesses, you can have it in dengue. So it's not, and so also Riger. So it's not that these are pathognomonic for malaria. Now, some of the other things which we look at is, muscle tenderness, which is seen in leptospirosis. If you have a rash, then you start thinking of dengue or rickettsial infections. And if the patient's fever has severe joint pains, like so much so that the patient is not able to move or not able to even lift a cup of water, you think of chikungunya. Conjunctival congestion is seen in lepto and adenoviral infections. Now, some of the other common coexistent symptoms like cough, headache, body ache, vomiting, loose stools are actually very non-specific and can be seen in almost all these kinds of fevers. So you can have a patient with influenza coming with fever and also loose stools. Similarly, you can see loose stools in leptospirosis, you can see loose stools in malaria, and you can have a cough even in dengue. So these symptoms really don't tell you so much. Of course, if you have a blocked nose and runny nose, then it's more likely to be a viral upper respiratory infection. So these are some of the clues to diagnosis. For example, this is a person who has icterus and conjunctival hemorrhage. So we know that this is leptospirosis. Similarly, this is a child who had fever and who had this lesion, which is an eschar. So you know you're dealing with a scrub typhus. And then this is a patient who had a flushed appearance. And when you actually put your fingers, you see a blanching. And this is basically the rash which you see in the early phases of dengue. So if you see something like this, when the patient is not febrile, then you know that you are dealing with dengue, and sometimes it may be difficult to appreciate in a dark-skinned person. Now, coming towards investigations, because as I said that you can't really differentiate all these illnesses, like malaria, dengue, leptospira, chikungunya, they all look more or less similar. You can have clinical clues, but you can't really make a definitive diagnosis. So then you will have to do your tests. Now, these tests are actually better done at 48 to 72 hours unless the patient is seriously ill, because many of the tests become positive by day 2, day 3. Even your changes in the complete blood count happen by that time. So, unless the patient is really sick, then you would not hesitate to do the tests even on day 1. You would probably do it at 48 to 72 hours. And another advantage of doing this is that sometimes by day 2 or day 3, the illness localizes. So a patient who's running high fever for 1 or 2 days, by the third day gets a sore throat or gets a runny nose, in which case you know that you're dealing with a viral upper respiratory infection and you don't really need to do the tests. The other question is that whether you do all the tests in series or in parallel. It depends on the level of sickness. So if you have a patient who's relatively stable, you will first investigate for the common things and then you will do in the next step other tests. Whereas if the patient is really ill and comes to the hospital, is admitted to the ICU, then you send off everything at one go because you don't want to make any delay in the diagnosis, and costs become less important here. Important for all of you, I mean, more than me, to understand that it has to be sent to a reliable lab. And sometimes, if your tests on the first day are not telling you anything, repeating the test helps. And I will demonstrate that to you in my subsequent slides, that how the initial CBC may be unremarkable, but doing it after 2 to 3 days may give you more information. So also for CRP. Another important message, which is more for clinicians than for pathologists, is to not order tests for diseases that are not in clinical consideration. Because sometimes, there is this whole labs, they offer a full fever panel. I mean, they do all kinds of tests in one. But sometimes, you are not thinking of some of these diseases in this, and therefore you would not want to do them. And but the most important thing is that the positive predictive value depends on the pre-test probability. That means, and this is just like a kind of table which tells you that suppose you have a disease where your pre-test prevalence is low, and you use a highly sensitive and specific test which has a sensitivity and specificity of 90%, which is very good. You find that your positive predictive value is only 50%. That means 50% of the times it is the diagnosis is false positive. On the other hand, when your pre-test prevalence is high, then your positive predictive value goes up to 90%. So remember that investigations are best done when the likelihood of disease is about 50%. Because suppose your pre-test prevalence is 90%, then the test really doesn't help you so much, because no matter what the result of the test, you will go ahead and treat the patient. And similarly, if the condition is unlikely, then also you don't want to do the test, because most of the times what you will be dealing is with false positive. So this is a principle which applies not only to investigation of fevers, but actually for any disease. Now, what are the first line investigations that we send for acute undifferentiated fevers in the Indian setting? And I mean, other people may do some other tests, but this is typically what I do in my clinical practice. And that is complete blood count with peripheral smear, which I think is the most useful test. And it also helps you in triaging your further tests. A C-reactive protein, tests for malaria, dengue, blood culture, urine routine with or without culture, chest x-ray, and ultrasound abdomen. So you may not do all these tests, but these are typically the first line investigations which you will do, and we discuss these one by one. Now, when we look at the complete blood count, the first parameter that we see is hemoglobin. Now, hemoglobin, like you have low hemoglobin in malaria, but in India, where nutritional anemia is so common, it may be difficult to interpret the hemoglobin thing. And your hemoglobin, if it is high, it tells you it's dengue, because in dengue you get a concentration because of a capillary leak. But remember that even other illnesses, like for when there is high fever and poor oral intake, you may get a elevated hemoglobin. But suppose you're getting a hemoglobin of 16, 17 or 18, then you know that you're dealing with probably dengue with capillary leak. Then the next parameter is the total leukocyte count, which is very important. Now, again, you will see that the total leukocyte count can be very low or low in many infections, especially tropical infections like dengue, chikungunya, influenza, acute viral hepatitis. In malaria, you have a low WBC count, and sometimes in overwhelming bacterial infections, you can have a low white cell count, which is actually a poor prognostic marker. The white cell count is usually normal in typhoid fever. And if it is high, it can even be a viral infection like EBV. Even in adenovirus, you can get a high white cell count. Bacterial infections, inflammatory process, leptospirosis, rickettsia, all these conditions have a high white cell count. But nothing is sacrosanct. You can have a lot of overlap. Now, the next step is to look at the differential count, to look at polys, lymphos, eosinophils. So polymorph predominance, you actually see in typhoid, you see in bacterial infections, and you can also see a polymorph predominance in viral infections. For example, in COVID-19, we all saw lymphopenia. In adenovirus, you will see a polymorph predominance. So polymorph predominance is not just seen in bacterial infections. If you have a lymphocyte predominance, you are thinking more in terms of a viral infection, including Epstein-Barr, where you have a high white cell count and you have predominant lymphocytes. Pertussis is another infection, though it's not an acute undifferentiated fever, where you have a high white cell count and lymphocyte predominance. Eosinopenia was initially considered important for diagnosis of typhoid, but in any acute infection, you actually have a stress response, high cortisol levels, and you get a eosinopenia, where your eosinophil percentage is 0 to 1%. But again, in patients who have a allergic diathesis or allergic predisposition, you may not find eosinopenia. Platelets, again, non-specific, but the degree of fall in platelet count helps. So if your platelet counts are very low, then it is more likely that you're dealing with diseases like dengue, malaria, leptospira, or rickettsial infections. Whereas if your platelets are normal or little low, then you can see that in other viral infections like flu, EBV. In typhoid, your platelet counts fall, but usually in the second week. And in serious bacterial infections, you can see a low platelet count, like a low white cell count also, because of a DIC-like situation. And then it doesn't stop with this. The peripheral smear is very important because it will tell you about the malarial parasite. It will tell you about reactive lymphocytes, which if are present point towards a viral infection. You can see atypical cells of mononucleosis. And if you see precursors like, immature neutrophils, myelocytes, metamyelocytes, or toxic granulations, you could be dealing with a bacterial infection. But as I said, that the trend of CBC is more important than a single value. And day one CBC is usually normal because Sometimes people do their blood count on day 1, and there it is very difficult to know what is happening. And sometimes you will have to repeat it on day 2 or day 3 to see the trend. And that is why we say that normally it is better to defer these investigations to the second or third day, so you can start making some sense of the complete blood count. Now, the next test is a C-reactive protein, and it is a protein which is produced by the liver in response to various types of stresses, including infections, trauma, inflammation, and it has a diagnostic value. It rises within 6 to 12 hours, peaks at 48 hours, and starts coming down in 72 hours. So, again, as I said, that even if you have a bacterial infection, the CRP on the first day may be normal. Again, a quantitative estimation is needed, qualitative estimation is not useful. And the usual levels of CRP are less than 10 milligram per liter. And again, I must point out that labs use different units. So you have milligram per deciliter and you have milligram per liter. And sometimes if the person has done a C-reactive protein from 2 different labs, you may actually have to look at the unit carefully, because sometimes you can otherwise make erroneous conclusions about the trend of the CRP. Uh, a CRP elevation of up to 40 can be seen, is very non-specific, can be seen in viral infections. But if you actually have high CRP, then higher the CRP goes, the more likely it is that you're dealing with a bacterial infection or you're dealing with an inflammatory process. But again, I want to remind you that certain viral infections like adenovirus, even COVID, were associated with high CRP. And if your levels are very high, then it becomes even more specific for a bacterial infection. But again, in many inflammatory disorders like Still's disease, or in cases of vasculitis or Kawasaki, you will have actually a high CRP in the absence of a bacterial infection. So, as I said, it is a non-specific marker. And there is no real cutoff of the CRP to differentiate between viral and bacterial infections. So remember that if you use a low cutoff, you have more sensitivity but low specificity. And if you have a higher cutoff, you have low sensitivity and high specificity. So there is no real watershed divide between the CRP for a viral and bacterial infection. However, like I said, for CBC, if you repeat the CRP after 1 to 2 days and you see the trend, then it may be more useful. And also, if your CRP remains persistently negative, then it has a higher negative predictive value for a bacterial infection. So again, as I said, that in short duration fevers, in viruses, you get a mild elevation. In bacterial and enteric, you have, elevation, moderate to marked elevation. Dengue, even if it is severe dengue, your CRP is usually normal. In malaria, it is high. And in leptospira, rickets cell, are the other infections where it is highly elevated. So, as I said, that mild elevations do not differentiate between viral and bacterial infections, should not be used to start antibiotic therapy, and trend in CRP may be more useful than a single CRP. It also helps in monitoring response to therapy. Procal, I'm not going to discuss much, because procalcitonin is, a rich man CRP. The thing is that procal is not elevated in viral infections and connective tissue diseases, and it rises faster than CRP and it peaks faster. But the procalcitonin is not normally needed in when you are investigating your routine undifferentiated fevers coming from the community. Now, moving on to malaria. I mean, US pathologists probably know about it more than me, but again, we have 2 important tests for malaria, and I'm just contrasting both of them in this slide. You have the smear, which can be thick and thin. You have to do both, and you have the antigen tests. So, when you look from this table, you find that the sensitivity of the smear, the thick smear, is more than a malarial antigen test, provided the pathologist has spent 20 minutes in looking at the slide. Again, you can make a species diagnosis by both tests, but assessment of the severity of malaria is possible only by the thin and thick smear, because it will give you a parasite count, which will tell you how severe the disease is. Also, it helps in following up therapy to show that the smear has become negative, because your antigen test can remain positive for even 1 week to 1 month after the patient has had malaria. And while the expertise required for the thick and thin smear is higher as compared to the rapid malarial antigen test, but again, kits are different, and Dr. Bhide will tell us more about them later. And if you have not stored the kits properly, you can get false negative results. Now, one more point which I wanted to make is that the overall incidence of malaria in India is coming down, and there are only some states which are highly endemic, which include the northeast and central eastern India. And the slight positivity rate has also come down. It is about 1% now. That means for 100 malarial smears, only one is positive. So therefore, there is no place for empiric anti-malarial therapy, which is often done in clinical practice. So if you're suspecting malaria and your smear is negative, look at other things. If your platelets are normal, white cells are normal, then it is most likely not malaria. And you can also repeat your thick smear every 6 hours, and it is not necessary to coincide it with the spike. And the sensitivity, however, if you are thinking strongly of malaria and your antigen and your repeated smears are negative, you can do a malaria PCR, which is now available, where the sensitivity is as good as 5 parasites per microliter. Now, moving on to dengue, which is one of the most common causes of short duration fever, you will see. You find that it is important to know the various phases of dengue. So you see that dengue is usually a illness in which the fever lasts for 5 to 7 days, and it slowly comes down to by day 5 or day 6. And this is the time where most of the patients who go into complications. Of course, the risk of complications in dengue is only about 1%. But you will see that this phase of complication is is reflected by the blood count. That means what you find is actually a rise in the hematocrit and a fall in platelet counts. That is why in a patient with dengue, doing serial CBCs is very important, because if you find that your hemoglobin is going up and your platelets are suddenly dropping, you can anticipate that this patient may have a complication, and you can look at these patients or monitor them more carefully. Similarly, the complete blood count recovery lags behind clinical recovery. So the first thing to happen is your fever goes away, then your white cells start improving, and then finally the platelets go up. So as I said, CBC is very important in the diagnosis of dengue, but we have to also do the serologic test. So in that sense, it is important to understand the dynamics of the antibodies and virus in dengue fever. So in dengue, you have two things. You have basically primary infection where because there are 4 serotypes of the dengue virus. So when you are infected by the one serotype for the first time, it's a primary dengue. But if you are infected later with another serotype, you are at higher risk of complications because of the phenomena of immune enhancement. So in primary infection, your viremia phase lasts for about, let's say, 0 to 6, 7 days, where your NS1 will be positive. Then you have a rise in IgM antibodies, which become positive and go up by 2 weeks, and then remain elevated for about 3 months to up to 1 year. And you later have a rise in IgG antibodies. Whereas when you have a secondary infection, your viremia period is shorter because your antibodies mop up the virus. So your NS1 declines early. Your IgM peak is smaller, but you have, on the other hand, a very rapid and a high IgG peak. So this is one of the infections where IgG is also helpful in diagnosis, unlike other infections where a positive IgG merely means that the patient has been infected in the past with that particular pathogen. That is why we have to look at all the 3 things when we diagnose dengue. When you look at NS1 antigen, its sensitivity varies between 70 to 90%, but it is highly specific, and its positivity goes down as the illness advances, especially after day 6 or day 7. And as I showed you in secondary dengue, your NS1 antigen may become negative after the 2nd or 3rd day. IgM dengue, on the other hand, is sensitivity is poor, because in early dengue up to day 7, where most of the patients are running fever and you do tests, your IgM may be negative. And also in secondary dengue, you may not see a IgM rise. On the other hand, the specificity is limited because of cross-reactivity with other flaviviruses, and also because your dengue IgM can persist for 3 months to 1 year. So that means if you actually have a patient with a febrile illness and your NS1 is negative and your IgM is positive, but none of the other things are fitting in with dengue, it is most likely that this IgM dengue is because of a past asymptomatic infection, which many of us living in India have. IgG, as I said, is important, and the kits which are available for IgG actually capture the high titer IgG, and therefore they detect secondary dengue infections and not the primary dengue. So the best sensitivity is when you do all the three tests: NS1, IgM, IgG, irrespective of whatever time the patient presents. And in that sense, we have a good test available, like the rapid point of care test, like Dengue Duo, where you have on a single immunochromatic capture test, you have NS1, IgM, and IgG together. Of course, the sensitivity of the immunocapture test is lesser as compared to the ELISA. So this is what the test looks like. It has a turnaround time of just 15 to 20 minutes. You all know this from the COVID antigen test that many of us were doing at home. And one of the algorithms which you can use for diagnosis of suspected dengue is this. So you first do a rapid test because the turnaround time is very fast. If your NS1 is positive, it is confirmed that it is dengue. If your NS1 is negative, but your IgM, IgG is positive, then yes, it is probable dengue, but keep other diagnoses in mind because, as I told you, IgM can remain positive for a long time. On the other hand, if both are negative, and you should keep other diagnoses in mind, but at the same time, you can run an ELISA because the sensitivity of ELISA is higher. Now, if the ELISA NS1 is positive, you're confirmed. If the ELISA IgM IgG is positive, then again, it's probable dengue. But if your ELISA is negative, then it can either be some other diagnosis, or you repeat the test. That will be for academic reasons, because after 1 or 2 weeks the patient would have anyway got better, or the diagnosis would have been revealed. Or you can do a dengue PCR, because that, again, like malaria, has the highest sensitivity for the diagnosis of dengue fever, and now it is readily available. And it's not so expensive. I think it costs about 1,500, 2,000 rupees, which is also the top cost for dengue serology. Now, coming to some of the other tests, like a urine analysis, you again, you would always want to do, because UTI often presents as fever without focus, and normally these burning dysuria may not be present because they are present in lower UTI and not in pyelonephritis. So you have to do a urine routine. It's an essential investigation in which you look at the nitrite, leukocyte esterase, pus cells, gram stain, or freshly centrifuged urine. And remember that pyuria may be present as a manifestation of any cause of fever. So few amount of pus cells, like 4 to 5 in the urine, you can see in any febrile illness. I mean, it is not representative for UTI. Always send a urine culture only if your urine routine suggests that it is UTI, because otherwise you may pick up asymptomatic bacteriuria and you may go down the wrong path. And remember, you should collect the urine properly, especially for culture. It should be a midstream specimen, and it has to be transported to the lab within 1 hour. Now, blood culture, which is the main test we do in acute undifferentiated fevers for diagnosis of enteric fever. And it can be a second line test if other diagnosis is ruled out and enteric seems likely, because sometimes it's an expensive test. So you initially just do your CBC, CRP, dengue, and malaria, and others are not there, and enteric is likely. Then you do a blood culture. Again, you have to follow precautions, collect the specimen properly, collect adequate volume. That means for an adult, it is 20 to 40 ml, one set, and the automated systems are better. And remember that the sensitivity of blood culture for typhoid is highest in the first week and before you give antibiotics. And remember also, Salmonella is a fastidious pathogen. So even if your patient has got antibiotics for 2 to 3 days, you should still send the culture, because it will grow, unlike pneumococcus or Hib, where the culture becomes negative even after a single dose of the antibiotic. And then you have to interpret the results carefully, because if you have grown coagulase negative staph in the blood culture, it is probably coming from skin contamination. If you're growing Burkholderia or Pseudomonas, it may be due to contamination in the antiseptic. Some of the other tests which we do in these patients include a liver function test, because you get mild elevation of AST, ALT in all tropical infections. But unlike acute viral hepatitis, your AST is more than the ALT. Creatinine also you do in most of these patients. Mild creatinine elevation can be seen in any fever due to dehydration, but if the creatinine is markedly elevated, then you start thinking in terms of leptospirosis, acute pyelonephritis, or severe dengue. Now, these are also radiologic investigations which we do in acute febrile illness, because chest X-ray may sometimes show a patch even if there's no cough, for which the term occult pneumonia is used. You do an ultrasound abdomen and pelvis because, especially if your initial investigations are non-contributory, you may pick up a liver abscess, you may pick up kidney problems or an abscess there, or cystitis, and you may also pick up subtle changes of enteric like terminal ileal thickening, mesenteric nodes, and splenomegaly. And nowadays, most hospitals, in patients coming with an acute febrile illness to the hospital and getting admitted to the ICU, often run a CT chest abdomen for quicker diagnosis of conditions like a pneumonia or pyelonephritis or acute cholecystitis, where it is essential to make a quick diagnosis for reasons of source control. Now, some of the other tests which you often do depending on clinical suspicion, like if you're thinking of leptospirosis in a patient, then you actually, the MAT is not available. So most of the people do an IgM ELISA. Unfortunately, that is a test which has poor sensitivity and low specificity. So in lepto, the PCR is the best test for, especially in the first 4 or 5 days of the illness. For rickettsial infections, you do scrub and spotted fever IgM, and you can do a PCR in blood. But unlike leptospira, where the PCR is a good test, for rickettsia, we don't have that much data or good tests available in the clinical domain. For chikungunya, again, your IgM chikungunya sensitivity is low in the first week of the illness, and chikungunya PCR is the preferred test. And remember about Zika, which you should suspect if a patient has a dengue-like illness and is negative for dengue or for chikungunya. And in these cases, you have to do a specific PCR in the blood or urine for Zika. Now, it's a little bit, couple of minutes about the multiplex PCR panels for tropical fevers. Now, these have really gained prominence in the current day, and most of the tropical fever panels have a multiplex PCR which tests for malaria, dengue, chikungunya, rickettsia, lepto, salmonella, West Nile. Now, if you look at the components of this tropical fever panel, malaria and dengue is not so important because for them you have good tests. You have the malarial antigen test or the peripheral smear, and you have the NS1 antigen. Salmonella, unfortunately, the diagnosis is not good on the tropical fever. PCR tests for salmonella have really not worked well. So therefore, this panel is mainly important for lepto, chikungunya, and rickettsia. So, and the cost of the panel varies from 5,000 to 10,000. So you may do these panels if you're thinking of lepto, chikungunya, or rickettsia, but remember that for these illnesses, you also have standalone PCRs available. So that is why if your patient looks like leptospirosis, then you can just ask for a lepto PCR because it's cheaper and it is more sensitive than the multiplex PCR. And remember, these PCR panels are second line tests which are used when the first line or the previous tests are not able to make a diagnosis. Otherwise, they are just not cost effective. And this is just one case I saw yesterday where, we had this case of a 62-year-old female who had fever for 3 days with burning micturition. Day 4, she had no fever but started feeling weak. Day 6, she was admitted to a hospital with shock and bilateral pleural effusions. And if you look at her blood counts, TLC was high, platelets were high, CRP was not so high, PCT was negative, urine showed from 5 to 10 pus cells. Now, dengue, malaria serology was negative and blood culture was negative. So it was not fitting into any particular type of fever because, you would think of urosepsis, but then the CRP is not so high. The procal is negative. If a patient with urosepsis is in septic shock, your procal is going to be very high. Similarly, malaria was negative, dengue was negative, and dengue you wouldn't think of because, of course, with the fever going down, the person going into shock fits with dengue, but the white cell count and the platelets are not like dengue. But when we sent the tropical fever panel, we found that she was actually dengue positive. So what I'm trying to say is that though what I told you about this total counts and platelets, what happens to them in dengue holds true, but sometimes it may not. And if you have a patient like this which does not kind of fit into any particular pattern, then you might want to do the molecular PCR panel, especially in the monsoon season. And then why am I talking about respiratory infections, molecular tests? Because, these are not these can come as an acute undifferentiated fever in the first 3 or 4 days. And therefore, adenovirus is one such virus which has been particularly notorious this year, presenting with fever lasting for more than 2 weeks with high white cell counts and high CRP. Therefore, in many of our patients on day 4, day 5, if they are not able to make a diagnosis, you can actually do a nasopharyngeal PCR also for respiratory viruses. But the main problem is that the cost is a major limitation and the treatment implications are few. So unless you make a diagnosis of influenza and treat that, this panel helps you in establishing a diagnosis. It helps you in antibiotic stewardship because you won't give unnecessary antibiotics to your patient, but it is expensive. Some of the tests which are often done but are not useful include an ESR, because it's not really useful in acute fevers. Vidal, again, is very, very commonly done. But remember, it is not a good test, especially the slide Vidal. It is not useful in the first week. And you can have titers of TO and TH of up to 1 in 160 just because of staying in an endemic area. Typhi.IgM is also a very, very often used test. And unfortunately, its sensitivity and specificity is not better than a Vidal, and it may actually help you if you have a positive typhi.IgM. You start thinking in terms of typhoid, whereas actually it may be something else. And again, Wheel Felix has a test which has 50% sensitivity and specificity, so it's no better than tossing a coin. So lastly, in the last 2 minutes, I just want to show you, and maybe at this point in time, people can write in their chat what they think of, because this is fever for past 3 days, Mumbai, no focus. And if you see this first patient, the count is 3900, predominant polys, platelets are slightly low, CRP is mildly elevated, dengue is negative. So what do you think it can be? You can put it in your mind, but basically this can be anything. But it's unlikely to be enteric fever, because in enteric, your white cells and platelets don't go down so quickly in the first 3 days. And the CRP is also not high. So they could still be dengue with a negative serology. It could also be something like influenza. It could also be chikungunya. So remember, therefore, this kind of counts, if you get, they don't really help you. Now let us look at this other case. This is a patient who came to us with a total count of 20,000, predominant polys, very low platelets, CRP very high, and dengue IgM was positive. So the patient came in septic shock, and he was referred as a case of dengue shock syndrome. But you can see that many things don't fit in with dengue, and when we actually did a lepto PCR, it was positive. So this was leptospirosis, but the dengue IgM was false positive. Now, for example, let's take a third scenario. A patient who has unremarkable counts, unremarkable platelets, mildly elevated CRP, MP negative, dengue rapid negative. Now, again, what can this be? So this can be anything, but this can be either enteric or it could even be chikungunya, because in chikungunya also you have mildly elevated CRP. So what I'm trying to say is that in the monsoon season, clinically the patients look almost similar, and even in lab tests, many of them look similar unless you have extreme values. So finally, I would like to end. I'm sorry about 5 to 7 minutes overtime because of the technical glitch. But finally, I would like to summarize by saying that acute undifferentiated fevers are a very common clinical problem. The etiology varies with season and geography, and you have to initially approach these patients with a careful history and physical examination. And many times you make a diagnosis and you don't have to do tests. And if you do tests, do it at day 2 or day 3, unless the patient is ill, and you should do tests guided by clinical differentials. The basic tests include CBC, CRP, urine routine, malarial parasite. Again, malarial parasite figures in every fever case, even though the incidence is very low, just because you don't want to miss it, because it's a potentially treatable illness. And in monsoon, you would do a dengue serology. Remember, for typhoid, the gold standard is blood culture, and it is not typhi.IgM or Vidal. And once your results come back, you have to look carefully at the results and interpret them properly. Look at the total count, look at the differential carefully, look at the peripheral smear, look at the pattern of fever, and try to decide what you're dealing with. And repeat the CBC, because it's a cheap test, and repeating it may give you more information than doing fancy investigations. And then finally, molecular tests are expensive and they should be used judiciously only in certain circumstances. With that, I would like to end my presentation and turn it over to the moderator. Thank you.
Thank you, ma'am.
Thank you so much, Tanu. It was, you were very much in time despite the fact for the little glitch or hitch that happened in the beginning. I've just asked the moderators, are there any burning questions in the chat box?
No, ma'am.
If not, I would ask Milind just to complement whatever Tanu was saying, because she talked a lot about, the laboratory, the role of the laboratory in the management of fevers. So would you like to say something, maybe comment on these multiplex tests and so on?
I've just made some, I'll just share my screen. I've just made few common points. Is that, as Madam rightly said, the malaria thick smear is still the gold standard. Not many people do it, but it's very easy to do. We require to use field stain in which we dehumanize the peripheral with the thick smear. And once you understand how to do it, it's a very, very good technique. We just require maybe 5 to 10 minutes to scan the entire smear, and the results are really great. As far as malaria antigen test, many people have switched over to malaria antigen because it does not require any kind of practice or technical expertise. But mind you, not all kits are good. Some kits are notoriously bad and they will miss even the commonest cases of Vivax malaria. As far as dengue is concerned, we have to remember that NS1 comes positive in only the first few days of infection. So as the patient progresses and the platelet counts start coming down, at that time NS1 may come negative. Platelet count is often done for during dengue and even in malaria. We have to always remember before we report a low platelet count to look at the entire smear, because it is possible that the smear has a lot of platelet clumps and the counter is given a falsely low count because of these clumps. And we may report a very low count when actually the platelets may be adequate with huge clumps sitting in the periphery of the smear. In addition to this, whenever we have the history that this patient is being followed up for dengue or malaria, and the patient is coming to us for repeat investigations, it will be wise to collect a citrate tube, because we also see cases of EDTA-induced platelet aggregation, where EDTA is the cause where the platelet count is low. So we always collect in citrate tube, also do the platelet count from the citrate tube. Citrate tube, when I say citrate tube, it is a tube which contains sodium citrate, which we commonly use for coagulation assays. So this tube should be collected in any patient where we have got a low platelet count. Another very important clinical variable is that the mistake to use 23G needles for blood collection. Today, many times, today it's very common to have multiple collection centers, multiple people collecting the sample. Some may not be well trained. And before you report a low platelet count, please ask what needle was used. So using a very small needle for collection will cause a very low platelet count. So I just thought that these are the few things which I would like to share in addition to what Madam has already said.